This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU webinar series. Today's topic is the brittle bones of osteoporosis. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Dr. Ahmed. Dr. Ahmed received his residency and fellowship training at the University of Connecticut Health Center. He is board certified in internal medicine and rheumatology. He works at Mather Rheumatology, where he provides care to patients with autoimmune inflammatory diseases and osteoporosis. He also provides rheumatology education and medical residence. Dr. Ahmed, let me get your PowerPoint up and then we'll get started.
Thank you. Good afternoon and welcome everyone to the HealthyU webinar on osteoporosis. Can we get the next slide? Yes, thanks. The word osteoporosis is from the Greek terms for porous bones. It is a systemic skeletal disorder characterized by low bone mass, microarchitectural deterioration of bone tissue leading to bone fragility, and a consequent increase in fracture risk. Bones that commonly break include the vertebrae in the spine, the bones of the forearm, and the hip. Fractures in the spine can lead to a curved back or kyphosis, as seen in this picture. Osteoporosis results in 1.5 million fractures per year in the United States, with a vast majority occurring in postmenopausal females. Next slide. Osteoporosis is defined in terms of how dense a person's bones are. Bone density peaks at about 30 years of age and then slowly declines over time, as shown in the graph on this slide. The most important risk factors for osteoporosis are advanced age in both men and women and female sex, estrogen deficiency following menopause or surgical removal of the ovaries is correlated with a rapid reduction in bone mineral density, while in men, a decrease in testosterone levels has a comparable but less pronounced effect. While osteoporosis occurs in people from all ethnic groups, European or Asian ancestry increases the predisposition. Those with a family history of fracture or osteoporosis are at an increased risk. At least 30 genes are associated with the development of osteoporosis. Those who have already had a fracture are at least twice as likely to have another fracture compared to someone of the same age and sex. Many studies have associated smoking with decreased bone health. Tobacco smoking inhibits the activity of osteoblasts, which are bone-forming cells, and is an independent risk factor for osteoporosis. Smoking also results in increased breakdown of estrogen, lower body weight, and earlier menopause, all of which contribute to lower bone mineral density. Certain medications have been associated with an increase in osteoporosis risk. These include glucocorticoids or steroids, certain anti-epilepsy drugs like phenytoin and barbiturates, proton pump inhibitors for stomach acidity such as omeprazole and lansoprazole, depot progesterone injections for birth control, aromatase inhibitors such as anastrozole used in breast cancer treatment, and certain diabetes medications such as rosiglitazone. Many diseases and disorders have been associated with osteoporosis. These include untreated hyperthyroidism, which is overactivity of the thyroid gland, Cushing syndrome, which is overactivity of the adrenal glands that produce excessive amounts of natural steroids in the body, prolonged immobilization, vitamin D deficiency, gastric bypass surgery, which can lead to decreased absorption of calcium and vitamin D, hyperparathyroidism, which is overactivity of the parathyroid glands that regulate calcium balance, inflammatory bowel and chronic kidney disease, and certain autoimmune diseases such as rheumatoid arthritis and systemic lupus. Next slide. Osteoporosis is a silent disease. The only time symptoms occur is when a patient suffers a broken bone. Osteoporotic fractures occur in situations where healthy bones would not break. They are therefore regarded as fragility fractures. A fragility fracture is defined as a broken bone due to a fall from a standing height. Some patients have silent fractures which cause no symptoms but are detected incidentally during X-rays performed for other reasons. Acute and chronic pain in the elderly is often attributed to fractures from osteoporosis and can lead to further disability and early mortality. The symptoms of a vertebral collapse or compression fracture, shown in this image, are sudden back pain, often with radicular pain, which is shooting pain due to nerve root compression, and rarely with spinal cord compression or cauda equina syndrome. Fractures of the long bones acutely impair mobility and may require surgery. Hip fracture in particular requires prompt surgery as serious risks are associated with it, such as deep vein thrombosis, bed sores, and pulmonary embolism, leading to an increased risk of death. There is an increased risk of falls associated with aging. Part of the fall risk is because of impaired eyesight due to many causes such as glaucoma and macular degeneration, balance and movement disorders, for example, Parkinson's disease, dementia, and syncope or collapse due to loss of consciousness related to an irregular heartbeat or cardiac arrhythmia. Next slide. Since osteoporosis is a silent disease, diagnosis requires screening tests similar to, for example, doing mammograms for detecting breast cancer. Those who should be screened include women who have had menopause either naturally or through surgical removal of the ovaries, men and women with a history of fragility fracture, and those on certain drugs or with medical conditions outlined in a previous slide. Dual energy X-ray absorptiometry, or DEXA, is a means of measuring bone mineral density using spectral imaging. Two X-ray beams with different energy levels are aimed at the patient's bones. When soft tissue absorption is subtracted out, the bone mineral density, or BMD, can be determined from the absorption of each beam by bone. While there are other methods for detecting osteoporosis, DEXA scan is the most widely used and most thoroughly studied technology. The results of a DEXA scan are reported as T-scores and Z-scores. The T-score is the patient's bone density compared to the average bone density in a control sample of people of a similar age. And the Z-score is the patient's bone density compared to a sample of healthy young adults. According to the World Health Organization criteria, a T-score of -1.5 or less is normal. Between -1.5 to -2.4 is osteopenia, and -2.5 or higher is classified as osteoporosis. Medications to prevent fractures are recommended for patients with a T-score of -2.5 or higher. Fracture risk assessment, or FRAX, is a clinical tool used for patients whose bone density in the neck of the femur is -1.5 or higher, but whose overall bone density is below the range of osteoporosis. The FRAX calculation is reported as a 10-year probability of fracture. Medications for fracture prevention are recommended in those with a 10-year probability of major osteoporotic fracture at 20% or higher, or hip fracture risk at 3% or higher. Next slide. Resistance training and weight-bearing exercises can increase muscle mass and bone density. Longitudinal studies have shown beneficial effects on skeletal microarchitecture in association with some forms of regular physical activity. Fractures result from falls, and the number of falls and the proportion of falls that result in fractures increases with age. Exercise and balance programs, for example, yoga and Tai Chi, may result in improved balance and an increase in muscle tone, and may secondarily reduce the risk of falls among some persons. Besides exercise, assessment of the home for hazards such as loose wires or throw rugs on the ground and slippery surfaces in the bathrooms, withdrawal of psychotropic medications when possible, and the use of a multidisciplinary program to assess risk factors are prudent strategies for potentially reducing the risk of falls. Other measures include stopping cigarette smoking, which is linked to reduced bone density, and excess alcohol intake, which can increase the risk of falls. Analyses of several large trials of both calcium and vitamin D supplementation have shown a small reduction in fracture risk, particularly among the institutionalized elderly or those with a low intake of calcium and vitamin D. However, vitamin D alone or calcium supplementation alone has not been shown to reduce the risk of fractures or increase bone density. Standard recommendations for most postmenopausal women with osteoporosis are for a total calcium intake of 1,000 to 1,500 milligrams per day through diet, supplements, or both, and a total vitamin D intake of 600 to 800 units daily. Next slide. Before we move on to the medications used for osteoporosis, I would like to review a couple of questions that frequently come up during treatment discussions with patients. The relative importance of the two rare side effects, including atypical fractures and osteonecrosis of the jaw, or ONJ, versus the benefits of osteoporosis therapy creates uncertainty and controversy in the minds of patients. The concerns of many people regarding these potential adverse effects with certain osteoporosis medications have increasingly become a barrier to treatment. Osteonecrosis of the jaw is a complication that can occur in patients receiving certain osteoporosis therapies who undergo dental surgery, such as root canal, dental implants, or tooth extractions. It causes pain and swelling of the jaw, and in severe cases may require surgery to remove dead bone from the jaw. I want to be very clear that this complication never occurs as a result of routine dental care, including cleaning and scaling or placement of dental caps. The incidence of osteonecrosis of the jaw is very low, estimated at less than 1 case per 10,000 patients receiving osteoporosis therapy. The incidence of this complication is much higher among patients with cancer who are taking higher doses of bisphosphonates or another drug called denosumab for treatment of bony metastases, and are often receiving high doses of steroids and chemotherapy for cancer, which can independently increase the risk of ONJ. In order to reduce the risk of ONJ, I advise my patients to stop their osteoporosis treatment 2 to 3 months prior and resume 1 month following any elective dental surgery. Atypical fractures of the thigh bone or femur have paradoxically been observed in rare instances of women using certain osteoporosis medications, even though these therapies are supposed to prevent fractures. Numerous clinical studies have examined the relationship between atypical femoral fractures and osteoporosis treatment. In all the studies, the incidence of these fractures is low, ranging from approximately 1 in 10,000 to 5 in 10,000 among patients on osteoporosis medications. Several, but not all, studies have suggested an increase in risk with more than 5 years of treatment with bisphosphonates, which are a class of osteoporosis medications. My practice, therefore, is to limit therapy with bisphosphonates to a period of 3 to 5 years, followed by a treatment-free interval or drug holiday, depending on the medication being used and the patient's clinical circumstances. Let us now move on to a review of medications for osteoporosis. Next slide. This table shows the medications approved by the Food and Drug Administration for treatment of osteoporosis. A class of drugs known as bisphosphonates has a proven track record and a long established role in the prevention and treatment of osteoporosis. Most bisphosphonates are now available as generics, and due to their effectiveness and low cost, these are my preferred medications for initial treatment of osteoporosis. The first drug is called alendronate with the brand name of Fosamax. It is given orally at a dose of 35 to 70 milligrams once a week. It is effective in reducing the risk of vertebral, non-vertebral, and hip fractures. Like other oral bisphosphonates, it is taken in the morning on an empty stomach with a full glass of water, and the patient should wait at least 30 minutes before eating, taking any other medications, or lying down. Heartburn or irritation of the esophagus is a common side effect, but can be minimized by taking the medication as instructed. Some patients can experience joint aches and pains. Rare side effects include ONJ, an atypical fracture of the femur as discussed previously. Risedronate or Ectronel is an oral bisphosphonate that is similar in all respects to alendronate, except that it is given once a month instead of once a week. Ibandronate or Boniva is also similar, except that it has not been shown to reduce the risk of hip fractures. Therefore, I no longer prescribe it to my patients. Zoledronic acid or Reclast is an intravenous bisphosphonate that is typically given once a year for 3 years to patients who cannot tolerate the oral formulations. It does not cause heartburn since it is given through an IV. Patients sometimes experience temporary pain in the joints and muscles, which typically resolves within 2 to 3 days after treatment. Bisphosphonates should be used carefully in patients with kidney disease and are best avoided in people who have very low kidney function or kidney failure. Denosumab or Prolia is an injectable biologic medication that is administered every 6 months. It is effective in reducing the risk of vertebral, non-vertebral, and hip fractures, and like the bisphosphonates, it can cause rare side effects of osteonecrosis of the jaw and atypical femoral fractures. Unlike bisphosphonates, it needs to be given indefinitely. One of its side effects is lowering of the immune system and an increased risk of infection, particularly skin infections. It is approved for treatment, but not prevention of osteoporosis, and it costs around $1,200 for a single dose as opposed to around $6 for a tablet of alendronate. Teriparatide, which goes by the brand names Forteo and Tymlos, is a derivative of parathyroid hormone, which plays a natural role in regulating calcium balance and bone health in the body. It is an anabolic agent, which means that it works by promoting the formation of new bone, as opposed to the other medications, which are anti-resorptive agents that work by slowing down the absorption of pre-existing bone. It is given as a daily injection. Common side effects include muscle cramps and nausea. It can lower the calcium level, which therefore needs to be monitored regularly during treatment. A rare side effect seen in laboratory animals is the risk of osteosarcoma, which is a type of bone cancer. Therefore, treatment with Forteo is limited to a period of 2 years over a lifetime, and it should not be prescribed to patients who have received radiation therapy for cancer. It is effective in reducing the risk of vertebral and non-vertebral fractures. However, no data are available to show its effectiveness in reducing the risk of hip fracture. The cost for 1 month of treatment is around $600. Calcitonin is another natural hormone in the body that regulates calcium balance. It is available in an injectable form and also as a nasal spray, which is approved for treatment but not prevention of osteoporosis. The main side effect is nasal irritation or congestion. It has not been shown to reduce the risk of hip fractures. Raloxifene or Evista is a selective estrogen receptor modulator or SERM, which works by modifying the action of natural estrogen in the body and is therefore reserved for females only. It is taken orally once a day and is approved for prevention and treatment of osteoporosis. It has not been shown to reduce the risk of hip fracture. The main side effects include a risk of blood clots and sometimes hot flashes, leg cramps, and nausea. Interestingly, it has also been shown to reduce the risk of certain types of breast cancer and therefore could be an option for some breast cancer survivors. Estrogens used to be prescribed to women widely in the past for osteoporosis and many other indications. However, following a landmark clinical trial called the Women's Health Study in 2003, it was found that estrogen supplements can increase the risk of breast cancer, stroke, and heart attacks. Therefore, their use in osteoporosis has been largely abandoned and is currently limited to management of symptoms such as intolerable postmenopausal hot flashes or vaginal dryness. Another drug not shown on this slide was approved in 2019 under the brand name of Evenity and generically known as romosozumab. Like Prolia, it is a biologic monoclonal antibody which is given as a monthly injection. It works by inhibiting the action of sclerostin, which is a protein regulator of bone metabolism. Like teriparatide, it is an anabolic agent that works by promoting formation of new bone. It loses its effectiveness with prolonged use, therefore treatment is limited to 12 months. It has been shown to reduce the risk of vertebral and non-vertebral fractures, but no data are available to show a reduction in the risk of hip fracture. The cost is around $1,800 per dose, and common side effects include joint and muscle pain. There is some concern that it may be associated with an increased risk of strokes and heart attacks, and should therefore be used cautiously in patients who have a history of or other risk factors for cardiovascular disease. I have not had an occasion so far to prescribe this drug to any of my patients. Next slide. Having reviewed the medications, let us now see who should receive them. Recommendations for medical treatment of osteoporosis are outlined in this slide. These recommendations were published in 2016 in the New England Journal of Medicine and refer to postmenopausal females, but are also applicable to other groups of at-risk patients, including males. In the US, most practitioners follow the guidelines from the National Osteoporosis Foundation. Eligible patients are those with a previous hip or vertebral fracture, a T-score of -2.5 or less, lumbar spine or femoral neck or a T-score between -1 and -2.5, with a 10-year probability of hip fracture at 3% or higher and major osteoporotic fracture at 20% or higher. Non-pharmacologic approaches, as previously outlined, include adequate daily intake of calcium and vitamin D, regular weight-bearing exercise, fall prevention strategies, muscle strengthening, and avoidance of smoking and excess alcohol intake. Pharmacologic approaches include the anti-resorptive or anabolic agents that we saw in the previous slide. Next slide. In conclusion, osteoporosis is a silent disease that does not cause any symptoms until a fracture occurs. Therefore, patients who are at risk need to be identified and screened through bone density tests or DEXA scan. Osteoporosis is a common disorder that is associated with an increased risk of disability, chronic pain, and premature death due to complications of fragility fractures, particularly hip fractures. Preventive strategies and prescription medications, when appropriate, are effective in reducing the risk of fractures, and the benefits of treatment far outweigh any side effects. This concludes the webinar, and I'll be happy to answer any questions. Thank you.
Thank you, Dr. Med, for your extremely informative presentation. If anyone has any questions, you can enter them in the Q&A feature at the bottom of the screen. All questions are anonymous to protect your privacy. Let's see. You can watch the recording later. It'll be on our YouTube channel and on our website as well. Dr. Med, are you able to see some of these questions?
Yes, so do you want, I'll just go ahead and read them. So
yeah,
the second question is, are the costly meds mentioned covered by Medicare? And the answer is not as well as they should be, which is sort of paradoxical because patients who are on Medicare are often the same patients who are at higher risk of osteoporosis and fractures. Medicare has this feature called a donut hole, which means that every year patients have to spend several $1,000s out of pocket, after which their Medicare coverage kicks in. With some recent legislation being passed, it's possible that the donut hole may be eliminated and therefore patients might get better coverage. Sometimes people who are on Medicare have secondary insurance, which can pick up the cost of the medication that's not being covered by Medicare. And another resource available to such patients is assistance from the manufacturers of the medications, which requires filling out some forms and financial paperwork, which then allows them to receive the medication. But the answer to your question is the coverage is not as good as it should be. However, it is covered once you meet your out-of-pocket expenditure through the donut hole. The next question is, why are some treatments mentioned not effective against hip fracture? And the answer is that it probably has to do with two things. One is the actual molecular structure of a particular medication that allows it to bind less effectively to tissues in the hip bone as compared to other areas that might reduce the effectiveness. And the other reason might be the way certain studies and trials were designed, where there weren't enough patients included in the sample to show a reduction of hip fracture. I'll move on to the next question. The question is, how long can one take Prolia? What is treatment after you stop taking Prolia? Well, Prolia or denosumab is recommended long-term, which means that a patient takes it as long as it works and it's not causing any side effects. If Prolia is not working or is causing side effects, then the options would be some of the other medications that we discussed earlier, such as an oral bisphosphonate tablet like Fosamax or an injectable bisphosphonate like Reclast, or daily injections of teriparatide hormone, which is called Forteo. The next question is, what is a good form of calcium to take? And the answer is that it depends on what suits a particular patient. Over-the-counter calcium is available as calcium citrate and calcium carbonate. Both are equally effective. However, in some patients, one formulation can cause side effects such as constipation, or another can cause diarrhea. So a patient can start either calcium citrate or calcium carbonate, see how it suits them. And if it suits them, continue. If not, switch to the other formulation. I have to say, though, that I no longer tell my patients to take calcium supplements in the form of tablets because it seems that dietary calcium is more effective, which means taking more dairy, such as yogurt and cheese and milk containing calcium, which gets absorbed better and seems to work better against fracture prevention as compared to taking calcium tablets. Now, some people are intolerant to dairy. In those situations, an over-the-counter calcium tablet could be taken. The next question is, what is the doctor's contact info? And that info can be provided by Jonathan. You can reach out to him for that information.
Yes, once the Q&A concludes, I'll send all attendees the PowerPoint if they want to review it again, and Dr. Ahmed's contact.
And then the next question is, why does a hip fracture contribute to premature mortality? Well, it's because not due to the fracture itself, but due to the associated complications that can occur. So for example, if a person breaks a hip, they become immobilized. They're not able to walk. They are forced to spend longer than normal periods of time lying down in bed. And what that does is it increases the risk of blood clots. A blood clot in the leg, for example, which is not fatal, but sometimes can break off and travel to the lungs, causing what's called a pulmonary embolism, which is a very serious complication. Other complications can occur, such as bed sores due to prolonged immobilization, which can lead to sepsis, and infections, which can be dangerous. And then overall loss of strength and weakness due to a fracture can increase the risk of further falls and more fractures. So that is why a hip fracture is a big concern in osteoporosis management, and that's the most important thing that we try to prevent through exercise and medications. The next question is, what should someone take if they have reflux? The most effective treatment for reflux is a class of drugs which are called proton pump inhibitors, including medicines like Prilosec or omeprazole and lansoprazole, etc. Now, as we had discussed during the webinar, there are some studies that show that people who take drugs like omeprazole long-term can be predisposed to osteoporosis. And if a patient has a risk factor for osteoporosis, such as being on omeprazole or other risk factors, then the management would consist of screening the patient through a bone density test or a DEXA scan to see if they have osteoporosis and then treating it accordingly. In some cases, another option where omeprazole or drugs like omeprazole are thought to be contributing to fractures and low bone density is to switch to an older type of medication called an H2 blocker. These drugs are also available over the counter under the brand name, for example, of Pepcid. And those drugs, while they may not be as effective for reflux, don't have any negative effects on bone health. The next question is, are there any foods that might help? The type of foods that are good for osteoporosis and reducing the risk of fractures are foods that are naturally rich in calcium and vitamin D. So that includes primarily dairy products such as milk and cheese and yogurt. For people who cannot ingest dairy, certain other types of foods, for example, orange juice or almond milk, certain brands come fortified with calcium and vitamin D. The labels include the amounts of calcium and vitamin D in the foods, and a person can add up those amounts to get to their target goal of 600 to 800 units of vitamin D and 1,000 to 1,500 milligrams of dietary calcium per day. The next question is, how long do you need to be on medications? It depends on what medication is being given. So if you're on a bisphosphonate, an oral bisphosphonate such as risedronate or Actonel or alendronate or Fosamax, the duration of treatment with those drugs is 5 years. If you're on an intravenous bisphosphonate such as Reclast or zoledronic acid, the duration of treatment with that drug is 3 years. If you're on the daily teriparatide injection or Forteo, the duration of treatment with that drug is 2 years. And if the medication prescribed is Prolia or denosumab, the duration of treatment with that drug is open-ended. That is, you take it as long as it works and doesn't cause any side effects. Now remember, these durations of treatment are recommended durations of treatment, and we sometimes have to modify the duration of treatment depending on how well the patient's tolerating the medication and how well the medication is working. The next question is, what are weight-bearing exercises? Weight-bearing exercises include, for example, walking a half-hour walk each day or more to strengthen the bones in your legs, and lifting small weights such as 2 to 3 pound dumbbells with your hands to strengthen the bones in your arms. The next question is, how much improvement in T-score by daily walks of 1 mile The answer to that is unknown. There haven't been any studies to my knowledge which have looked at actual changes in T-score based on the amount of walking that a person does. But we can infer from all the other information that we have that it is a positive effect on the T-scores if you do exercise regularly. The next question is, can you add any information about osteonecrosis of the jaw while taking Fosamax? Osteonecrosis of the jaw while taking Fosamax or other drugs similar to Fosamax is a rare complication. It occurs in about 1 in 10,000 patients, so it's not a common side effect at all. And we prevent it by stopping Fosamax 2 to 3 months before any elective dental procedures, which reduces the risk to close to 0. And of course, if there's an emergency requirement for getting a tooth extracted or an emergency root canal, then the patient goes ahead and has the procedure as necessary. Patients should inform, and dentists are usually very good about asking patients whether they are on Fosamax or other drugs similar to Fosamax so that they can screen for osteonecrosis of the jaw and manage it early on. The next question is, are there any treatments for osteopenia? The treatment of osteopenia consists of prevention through regular weight-bearing exercise, inadequate intake of calcium and vitamin D, and avoidance of risk factors such as smoking and excessive alcohol consumption. Medications for osteopenia are prescribed to certain patients based on their fracture risk. If you remember, we talked about the FRAX score or fracture risk assessment score, which is applied to people with osteopenia who have a T-score of -1.5 at the neck of the femur. And in a patient with osteopenia, if the 10-year probability of a major osteoporotic fracture is 20% or higher, and hip fracture is 3% or higher, then the same medications that we use for osteoporosis are prescribed for osteopenia. Next question is mononucleosis considered an autoimmune disease as a risk factor? I've had it for decades, but is inactive in blood work. And the answer is that mononucleosis is not a risk factor for osteoporosis. There are other autoimmune diseases such as systemic lupus and rheumatoid arthritis, which are risk factors for osteoporosis, but not mononucleosis. The next question. I get Xgeva shots every month now due to my prostate cancer becoming active again. I take 600 milligrams of calcium in D3 2000. Should I be concerned about osteonecrosis of the jaw? And the answer is no. But I would recommend getting screening for osteoporosis through a bone density test. The next question is, does methotrexate cause bone to not heal after tooth extraction? What would be the advice regarding staying off methotrexate after tooth extraction? How long is it necessary to stay off methotrexate before tooth extraction? Methotrexate can interfere with healing of skin injuries. For example, an incision in the skin during surgery, if you're on methotrexate or if you get a cut on the skin, might take longer to heal compared to people who are not taking methotrexate. However, it does not have any negative effects on bone healing or tooth extraction. So a patient who is on methotrexate does not need to stop methotrexate before or during a tooth extraction, unless there's an infection, because methotrexate lowers the immune system. In that case, one should stay off the methotrexate until the infection has resolved and the symptoms of infection have disappeared for at least 1 week. Next question is, how long was Prolia tested in trials? When did Prolia come on the market? The duration of trials was anywhere between 1 year to 5 years. And when did it come on the market? I can't say exactly, but it's probably been available for at least the past decade. Next question. There are calcium supplements that are plant-based that include vitamin K2 as well as D3, and that's a good point. Some people who cannot use dairy-based calcium supplements can use the plant-based supplements. Vitamin K is not necessary for bone health, but certainly vitamin D is beneficial. Next question. Is there a generic drug on the market equal to Prolia? Not at this point, but our work is being done on development of what are called biosimilars, which are sort of the generic equivalent of biologic therapies such as Prolia. When such an agent might become available, I don't have that information, but it's not available at this time. Are there supplements recommended over Caltrate or Citracal? It depends on how a patient tolerates it. Some patients tolerate Caltrate better or Citracal better. So it depends on your individual experience. But in terms of effectiveness, there is no difference between the two preparations. Next question. How often do you recommend diet, exercise, weight-bearing training rather than medical drugs outlined here? I do recommend that as options for all of my patients, so I always recommend those approaches. There are some cases where patients, even though they might have osteoporosis with a T-score of -2.5 or less, are otherwise not at risk of fractures, particularly patients who are younger sometimes are diagnosed with osteoporosis, but they have no other risk factors. They don't smoke, they exercise regularly, their eyesight is good, their muscle strength is good. And in those cases, I recommend the preventive strategies rather than medications. It's always a decision that's arrived at through mutual discussion and agreement between the prescriber and the patient. And there are some patients who prefer not taking medications, which has to be respected. Next question. I eat a good amount of yogurt and cheese. Is it necessary to take calcium, and should I take D3 2000? And the answer is, if you are eating adequate amounts of yogurt and cheese and your calcium intake is 1000 to 1500 milligrams and vitamin D is between 600 to 800 units daily, you don't need to take extra calcium or vitamin D. Next question. Is thyroid medication connected to osteoporosis? It is not directly connected to osteoporosis. Naturally overactive thyroid or hyperthyroidism is a medical condition that can cause osteoporosis. Some patients who take thyroid medication for low thyroid function or hypothyroidism can have higher levels of thyroid medication than is necessary. However, typically your doctor who's prescribing the thyroid medication periodically checks your thyroid function tests in the blood. And as long as those thyroid function tests are in the normal range, taking thyroid medication should not cause osteoporosis. The next question is, if you have reflux, what is the best medicine to take for osteoporosis, since you can't take oral treatments for osteoporosis? And in patients who have reflux, taking Fosamax or Resveratrol can activate the reflux. So in those cases, we use the injectable drugs, such as Prolia or Reclast. Next question. Does wearing a weighted vest help or qualify as a weightlifting exercise? And I would say that it might, but it's not something that I commonly recommend to my patients. Carrying extra weight might create other issues such as pain in the lower back, but if it's something that you've tried individually and can tolerate, it might be beneficial to strengthen the bones in the spine. Next question. Does tamoxifen also help with reducing osteoporosis since it's in the same class as raloxifene? And the answer is yes, it does. However, it has not been shown to reduce the risk of hip fracture, so it's not used primarily as a treatment for osteoporosis, more used as a prevention in certain types of breast cancer. Next question, what exercises should one with osteoporosis not do? Weight bearing or yoga? Weight bearing and yoga are both good exercises for osteoporosis. I would say things to avoid would be high impact exercises or exercises or activities where there is a risk of fall. For example, skiing would not be recommended in somebody who has osteoporosis. The next question, I think, has already been answered. Okay, so the next question is, having positive PPD test, does it increase chance of getting TB if you take Prolia? Prolia theoretically can lower the immune system. So if somebody has a positive TB test, theoretically it might increase the risk of getting TB. However, in practical experience, that seems not to be an issue. So if you look at the package insert for Prolia, it does not actually call for getting a TB test before starting treatment. So it would be safe to take Prolia in that situation. Skin infections seem to be more of an issue with Prolia. So if a person has a history of recurrent skin infections, and that patient, Prolia might need to be used more carefully or be monitored closely during treatment. What is the difference between D2 and D3? D2 and D3 are different forms of vitamin D, which are called isomers. And they have similar effectiveness in terms of reducing the risk of fracture and in terms of their effects on bone health. Generally, when a patient is diagnosed with vitamin D deficiency, vitamin D2 or ergocalciferol is prescribed initially, and vitamin D3 or cholecalciferol is prescribed later on, just because of better absorption of ergocalciferol or D2 in the early stages of treatment. And the last question is, I have lost 6% in the spine and 2% in the hip in the past year, and Prolia was recommended for 1 to 2 years and then reclassed for 2 to 3 years. What happens after that? Must one continue with medications? If so, which ones and for how long? I am 70. That's a good question because what that brings up is judging the effectiveness of treatment of osteoporosis. So traditionally, that was done through serial measurements of bone density or DEXA scans every 2 to 3 years during treatment. I have found that approach not to work that well precisely because of the situation that this questioner finds themselves in, which is that a patient is prescribed a medication, and then after 2 to 3 years of treatment, the bone density is rechecked and it's changed. It's either negative or not improved. And then another medication is prescribed, and after 2 to 3 years, bone density is rechecked, and it's either the same or worse than before. And you would think that that's a bad thing, but actually it's not, because practical experience shows that changes in bone density measurement over time are not very meaningful predictors of fracture risk, so that changes in bone density don't have a very tight correlation with fracture risk. So in my practice, I have actually backed off on checking people's bone density once they're on treatment. There are individual patients who are interested in answering that question, and I do perform a bone density in that case after counseling the patient that the results may not impact their treatment. Because after all, what we are really looking for is fracture risk reduction. And now, although it's a crude measure of effectiveness of therapy, as long as a person doesn't experience a fracture while on treatment, we assume that the treatment is working. With reference to this particular case, in terms of what to do, I would say that if you have had reclassed and you were on Prolia before, I would recommend after completing your reclass that you should resume taking Prolia, because that's something that you took before and presumably tolerated well. And don't bother about having another bone density test. If your goal is really to see an improvement in the numbers in your bone density, then another option would be 2 years of treatment with an anabolic agent, teriparatide, which is Forteo or time loss. And after 2 years of treatment, switch back to Prolia. So those would be the options. And those are all the questions we have.
All right, thank you, Dr. Ahmed, and thanks for everybody for joining us today. If you have any additional questions, please email them to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you can please complete the survey, your feedback is extremely important to us and helps us plan our future programs. Thank you again all for joining today's webinar. If you'd like to see previous HealthyU webinars that we have presented, you can find them at www.matherhospital.org/HealthyU. Thank you again.
Thank you.